Hello everyone, welcome to the session of Approach to Thrombocytopenia. Thrombocytopenia is low platelet count. Normal reference range for the platelet count is 1,50,000 per microliter to 4,50,000 per microliter. If platelet count is less than 1,50,000 per microliter, then it is called a thrombocytopenia. However, platelet count between 1 lakh to 1,50,000 per microliter do not necessarily indicate disease if they have been stable for 6 months. So, platelet count below 1 lakh per microliter may be more appropriate definition to identify pathologic condition. Severe thrombocytopenia is when the platelet count is below 30,000 per microliter, and spontaneous bleeding risk increases when platelet count less than 20,000 per microliter reaches. Let's have a look at some of the causes of thrombocytopenia. We will divide the causes into the outpatient causes and the inpatient causes. ITP is immune thrombocytopenic purpura and DITP is drug induced ITP. Examples of the drugs are heparin, quinine, sulfonamide, ampicillin, vancomycin, piperacillin, ibuprofen, naproxen, cimetidine, etc. Infections like HIV, hepatitis C, H. pylori, CMV, and other viral infection, malaria and dengue. Connective tissue disorders like SLE, rheumatoid arthritis, antiphospholipid syndrome. Vaccination or drugs like valproic acid, daptomycin, linezolid, MDS, congenital thrombocytopenia, and common variable immunodeficiency. Let's see inpatient causes. First is multisystem illness or in the ICU, when the patient is in ICU. And then the causes of thrombocytopenia in such type of patients are infection, TTP or HUS, DITP, DIC, liver disease. HIT means heparin-induced thrombocytopenia or bone marrow disorders. In the patients with cardiac conditions, certain type of treatment is required like heparin or cardiac bypass surgery or GP2B3A inhibitors and other drugs. They can induce thrombocytopenia. And third is pregnancy or postpartum associated thrombocytopenia. The causes are gestational thrombocytopenia, ITP, HELLP syndrome, preeclampsia, abruptio placenta, TTP or HUS. In evaluation of thrombocytopenia, role of history and examination is very important. It is very important to take relevant history for the diagnosis. Required history is family history, bleeding manifestation, if any chronic disease like autoimmune disorders, infections or malignancies are present or not, pregnancy status in premenopausal woman, recent medication or vaccination or travel, transfusion or organ transplantation. In the examination, see for organomegaly, any bleeding tendencies, and any ischemic skin necrosis. Role of laboratory is very important in evaluating patients with thrombocytopenia. Peripheral blood smear must be carefully observed. All three blood cell lineages should be assessed. In critically ill patients, immediate information we need to obtain is whether it is thrombotic microangiopathy or acute leukemia. Even a short delay can be proven fatal for patient. So it is an emergency to diagnose the cause of thrombocytopenia in such cases. On peripheral blood smear, we should check for artifactual thrombocytopenia. The platelet clumping can be caused by EDTA-dependent platelet antibodies. One should repeat the CBC after collecting the blood sample in the citrate vacuity for the correction of the platelet count. We first study the RBC morphology. The presence of RBC fragments known as cystocyte is indicative of TTP, HUS or DIC. I have described TTP and HUS in detailed video in Approach to Hemolytic Anemia. The link is in the description below. Microspherocyte may suggest Evans syndrome. Macrocytosis and hypersegmented neutrophil suggest vitamin B12 or folate deficiency. Dacrocytes, also known as teardrop cells, suggest myelofibrosis. Nucleated RBC suggest hemolytic anemia, myelofibrosis, or an infiltrative process of bone marrow. Parasites. The presence of intracellular parasites like malaria is diagnostic of infection. Let's observe the WBC morphology. Leukemic cells, blast cells suggest malignant hematological disorder. Presence of hypolobulated neutrophils, also known as Palgar-Hewitt anomaly, suggests myelodysplastic syndrome. Dark coarse granule in the neutrophils suggest sepsis. Atypical lymphocytes suggest viral infection. Let's observe the platelet morphology. Consistently large platelet suggests hereditary thrombocytopenia. Large platelet with grey color on the right Giemsa stain suggests a grey platelet syndrome, which is associated with the bleeding tendencies, and that is due to the absence or the greatly reduced alpha granules of the platelet. In thrombocytopenia, due to peripheral destruction of platelet, large platelet and the normal size platelet both are seen. In MDS, platelet have variable size and they are hypogranular. In Wiskott-Aldrich syndrome and the X-linked thrombocytopenia, platelets are small in size. Other additional investigation we can do are LFT, RFT, clotting profile with D-dimer and LDH. If etiology is unclear after the workup, bone marrow aspirate and the biopsy should be performed to rule out primary bone marrow disorder. Immature platelet fraction is important to discriminate between thrombocytopenia due to bone marrow failure and hyperdestructive thrombocytopenia. Now we discuss about isolated thrombocytopenia. Isolated thrombocytopenia is low platelet count in the absence of abnormalities of RBC and WBC lineages and no signs or symptom of systemic illness. Most important cause of isolated thrombocytopenia are ITP and DITP. ITP is immune thrombocytopenic purpura. It is autoimmune disorder characterized by the low platelet count, purpura and hemorrhagic episode caused by the antiplatelet antibodies. Severe thrombocytopenia is platelet count less than 30,000 and bleeding may start when the platelet reaches less than 20,000 per microliter. Treatment for ITP is corticosteroid, immunoglobulin and drug for the increased platelet production like romiplastin and rituximab. DITP is drug-induced thrombocytopenia. The mechanism is development of drug-dependent antibodies against the new epitope of the platelet glycoprotein created by their interaction with drug. HIT is heparin-induced thrombocytopenia. It is suspected when the patient who has more than 50% decrease in the platelet count compared with baseline or total platelet count less than 1 lakh per microliter with normal baseline count on heparin therapy. Clinical manifestations of the HIT are venous or arterial thrombosis, necrotic skin lesions at the heparin injection site, or acute systemic reaction. Diagnostic test for HIT is heparin PF4 antibody testing. Although the test requires time, so the clinical scoring system for HIT is known as 4TS, which includes thrombocytopenia, thrombosis, timing, and other causes of thrombocytopenia are included for the management of the patient. This picture is showing the scoring system of HIT. If the score is between 6 to 8, then high chances of HIT. If the score is between 4 to 5, then intermediate chances of HIT, and the score is low 0 to 3, then low chances of HIT. Gold standard diagnostic test for HIT is 14C serotonin release assay. In patients with strongly suspected HIT, heparin should be stopped and alternative anticoagulants should be administered. Next is DIC. DIC is consumptive coagulopathy. It is characterized by activation of intravascular coagulation with microvascular thrombi formation, thrombocytopenia, depletion of coagulation factors, bleeding complications, and the end organ damage. Acute DIC is seen in severe sepsis, septic shock, after trauma, after surgery, as an obstetric complication, after ABO incompatible blood transfusion, and as a complication of APML. There is no single laboratory test for accurate and the precise diagnosis of DIC. The ISTH committee has proposed a scoring system. If overall score is more than equal to 5, then it is consistent with overt DIC. And if the score is less than 5, then it is suggestive of non-overt or low-grade DIC. Thrombocytopenia in pregnancy. Most common cause of thrombocytopenia are gestational thrombocytopenia, preeclampsia, and ITP. GT is seen in the mid-second to third trimester of pregnancy, and it is extreme variation of physiological decrease of platelet count in pregnancy. No confirmatory test available for GT, and it is a diagnosis of exclusion. Conclusion is prompt recognition of cause of thrombocytopenia is crucial for the correct management of the patient, as in APML, heparin-induced thrombocytopenia, TTP, HUS, DIC. This is the reference for this video. Thank you.